1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, charter
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Imagine, if you will, living your entire existence inside this like 98-degree, completely pitch black sensory deprivation tank.
Right, just totally automated and perfectly comfortable.
Exactly. I mean, you've never felt cold,
Right.
You've never felt gravity, you haven't even had to, pump your own blood or inflate your own lungs.
Because the placenta is doing all of that heavy lifting for you.
Yeah, this external machine is just running everything. And then, without warning, you are forcefully expelled into this freezing, blindingly bright room.
Talk about a rude awakening.
Seriously, the external machine is cut off. You suddenly have to inflate your own lungs, reroute your entire cardiovascular system, and generate your own body heat.
All in a matter of seconds.
Right. And if you don't accomplish this massive biological overhaul in about 60 seconds, you die. I mean, that is the physiological reality of every single newborn experiencing the transition to extrauterine life.
It's actually the most dangerous, complex, and honestly violent biological shift a human being will ever go through. Yeah, and for you, the nursing professional standing at the bedside, the stakes are absolute. I mean, the line between a perfectly normal transition and a rapid physiological collapse is razor thin.
And I imagine to an untrained eye, those two things can look terrifyingly similar.
Oh, absolutely. They look almost identical sometimes, which is exactly why we are doing this deep dive today.
Right. We're taking a massive stack of source material on newborn adaptation, physical assessment, and routine OB care. And our mission today is to act as your elite OB nursing educators, your clinical mentors, and your exam coaches.
We are getting aggressive with the Pareto principle today.
Yeah.
We are not just going to read a textbook at you.
Thank goodness. Nobody wants that.
Right. Instead, we're zeroing in on that 20% of clinical concepts, the core patterns, the high-yield facts that will give you 80% of your exam value.
Because passing the nursing boards, and honestly, being a safe nurse isn't about memorizing flashcards, it's about clinical judgment.
Exactly. It's about separating expected normal findings from those critical red flags. We're going to explain the why behind the pathophysiology.
So you don't have to just memorize a list, you'll actually understand the mechanics.
Exactly. If you know why it happens, you don't have to memorize it.
Yeah.
We're going to focus heavily on prioritization, patient safety, and those classic NTLE-X style traps that test writers use to trip you up.
So let's just kick things off at minute 0, the golden transition. The umbilical cord has just been clamped, the baby is wet, the room is cold, and the countdown begins.
The clock is literally ticking.
Right. So looking at the hierarchy of needs here, the absolute first biological hurdle is airway and breathing.
Always airway first.
Right. So the source material notes that fetal lungs are filled with fluid, which is secreted by the airway epithelium. And that's actually necessary for lung growth in utero, right?
Yes, it keeps the architecture of the lungs developing properly.
Okay, so that first breath isn't just taking in air, it's displacing a massive amount of liquid. But if those alveolar sacs are wet, I'd imagine the surface tension would make them snap completely shut the second the baby exhales.
Like trying to pull apart a wet plastic bag.
Yes, exactly like that. It sounds exhausting.
Well, it is. And that surface tension physics is the exact mechanism that causes so much distress in premature infants.
Okay, unpack that for me. How does a term baby get around the wet plastic bag problem?
So to keep those sacs from sticking together, the body produces surfactant. It's this highly specialized lipoprotein that coats the inner lining of the alveoli.
Okay, so like a biological lubricant.
Basically, yeah. It acts directly at the air-water interface to reduce surface tension. So when the newborn takes that very first powerful breath, the air physically forces the lung fluid across the alveolar membrane into the pulmonary capillaries and the lymphatic system.
It just pushes the fluid right out of the way.
Exactly. But it's the surfactant that keeps those tiny air sacs propped open during exhalation. That establishes functional residual capacity.
Got it. So without adequate surfactant, like in a premature infant, what happens?
The alveoli collapse flat after every single breath, and the newborn basically exhausts all their metabolic energy just trying to pry their own lungs open again and again.
Oh man, that makes so much sense. Okay, so the lungs inflate, the fluid gets pushed out, and oxygen floods the alveoli. But this doesn't just solve the breathing problem, does it?
No, it triggers a massive cardiovascular chain reaction.
Because in utero, the blood flow is completely bypassed away from the lungs, right? The placenta is the thing doing the oxygenating.
Right, the lungs are basically offline, and this bypass involves 3 major fetal shunts. You have the ductus venosus, the foramen ovale, and the ductus arteriosus.
Okay, the hemodynamics of this moment are just wild. Let's look at the pressure shifts.
Let's do it. So in a fetus, pulmonary vascular resistance is incredibly high. Why? Because the lungs are collapsed and filled with fluid.
Right, and blood takes the path of least resistance.
Always. So blood comes from the placenta via the umbilical vein. The ductus venosus shunts it past the immature fetal liver directly into the inferior vena cava.
Okay, so it bypasses the liver.
Yep. Then it hits the right atrium of the heart, but it doesn't want to go into those high-pressure collapsed lungs, so it shoots straight through the foramen ovale.
Which is what, like a literal flap valve opening between the right and left atria?
Exactly. It's a literal hole with a flap. It shoots right into the left side of the heart to be pumped to the rest of the body.
Okay, but what about any blood that happens to sneak down into the right ventricle and gets pumped toward the pulmonary artery?
That gets caught by the third shunt, the ductus arteriosus. It basically just grabs that blood and dumps it right back into the descending aorta.
It is a highly efficient bypass system. But the moment the provider clamps that umbilical cord, this entire pressure dynamic just completely flips, doesn't it?
Instantly. Clamping of the cord removes the low-resistance placental circuit. So systemic vascular resistance suddenly skyrockets.
Because the easy path is gone.
Right. And simultaneously, the baby takes that first breath. Now, oxygen is a potent pulmonary vasodilator.
Oh, so as the lungs expand with oxygen, the pulmonary arterioles open up.
Yes. And pulmonary vascular resistance just plummets.
So if the systemic pressure in the left side of the heart suddenly shoots up because the placenta is gone, and the pulmonary pressure on the right side of the heart suddenly drops because the lungs just opened up.
That pressure differential literally reverses the flow. It slams the door shut on those shunts. The higher pressure in the left atrium mechanically pushes the flap of the foramen ovale closed.
It's entirely pressure-driven. That is so cool. But this brings us to a massive clinical trap for nursing students, doesn't it?
Oh, a huge one. Listen closely to this. You're at the bedside. The baby is an hour old. You place your stethoscope on the chest, and you hear a distinct heart murmur.
And as a new nurse or student, your immediate instinct might be to just panic and call a code blue, right? Like suspecting a severe congenital heart defect.
Exactly. You think the worst. But a transient murmur on the first day of life is actually an expected, normal finding.
Wait, really? A murmur is normal?
On day 1, yes. You are simply hearing the turbulent blood flow as those functional shunts, specifically the ductus arteriosus and foramen ovale, are in the final stages of completely sealing shut.
Oh, so it's just the sound of the doors closing, basically.
Exactly. It does not require a code blue. It requires documentation and continued monitoring. That is a high-yield exam concept right there.
Write that down.
Oh.
So, which means we need to know what the normal expected vital signs are during this transition versus what actually indicates distress.
Right.
The baseline heart rate for a newborn is incredibly fast compared to an adult. The sources state an expected heart rate of 110 to 160 beats per minute.
And an expected respiratory rate of 30 to 60 breaths per minute.
Okay, so those are your safe baselines, and the exam questions will absolutely test your ability to recognize when a newborn deviates from them into respiratory distress.
They love to test respiratory distress signs. So if you see grunting, which is the baby exhaling against a partially closed glottis to try and keep those alveoli open, that is a major red flag.
It sounds like a little noise, right?
Yes, like a little rhythmic whine or grunt. Nasal flaring is another one. That's an attempt to pull in more oxygen. And retractions are a massive warning sign.
Retractions are when you see the skin sucking in around the ribs or the collarbones, right?
Because the baby is using accessory muscles to forcefully expand their chest cavity. They're working so hard to breathe.
And what about color?
Central cyanosis. That's a blue discoloration of the lips, the face, or the chest. It means the vital organs are hypoxic.
So if you see grunting, flaring, retractions, or central cyanosis, the transition is failing. You have to intervene.
Immediately.
Okay, so we have the airway clear and the cardiovascular shunts closing, but there is a third, equally critical pillar of this golden transition: Thermoregulation.
The ability to maintain body temperature.
Right, because going back to our initial analogy, the baby just got kicked out of a climate-controlled smart house into a freezing cabin. They need heat.
And fast.
But a newborn lacks the muscle mass and neurological maturity to generate heat through shivering thermogenesis, right? Like, you'll never see a newborn physically shiver to warm up.
Never. If a newborn is shaking, it's not a shiver. It might be a seizure or hypoglycemia, but it's never shivering for heat.
So how on earth do they survive the temperature drop?
They rely entirely on a biochemical process called non-shivering thermogenesis, and this involves the metabolism of brown adipose tissue or brown fat.
Brown fat, I've heard of this.
It's amazing stuff. It's a highly specialized, highly vascularized fat deposit. It's located around the newborn's neck, between the shoulder blades, surrounding the kidneys, and in the armpits.
So when the skin receptors detect a drop in ambient temperature, what happens?
The sympathetic nervous system triggers the rapid breakdown of this brown fat, and that generates profound amounts of heat, which is then carried throughout the body by the rich blood supply.
Okay, but breaking down that fat has a metabolic cost. Burning anything requires fuel. And in this case, the fuel is oxygen and glucose.
Yes. So if a baby is struggling to breathe, say they have a compromised airway or retained lung fluid, they physically cannot metabolize the brown fat effectively.
Because they don't have the oxygen to burn the fuel.
Exactly. This is perhaps the most critical exam concept in newborn physiology. We call it the hypoxia-hypothermia death spiral.
That sounds terrifying.
It is. You cannot view thermoregulation and oxygenation as two separate systems. They are deeply intertwined. A hypoxic baby cannot produce enough heat because they lack the oxygen required to burn brown fat. That leads to severe hypothermia.
And it goes the other way too, right?
Oh, absolutely. If a newborn gets cold, they will furiously burn brown fat to warm up, which dramatically increases their metabolic rate.
Which means they're consuming a massive amount of oxygen.
Right. And that massive consumption will rapidly deplete their reserves, throwing them right into hypoxia and hypoglycemia. It's a vicious cycle.
So keeping them warm is literally a matter of keeping their oxygen levels stable, and keeping them oxygenated is a matter of keeping them warm.
You can't have one without the other.
Which makes the priority nursing action at the moment of birth incredibly clear. I mean, the delivery room is significantly colder than the womb, and the newborn is completely covered in amniotic fluid.
And water conducts heat away from the body exponentially faster than air does.
So what's the priority?
The number one priority action right after delivery is drying the newborn aggressively and immediately.
Just get them dry.
Evaporative heat loss is your greatest enemy in those first few minutes. As that amniotic fluid evaporates off the skin, it takes the baby's body heat right with it.
A newborn's core temperature can just plummet within minutes if they're left wet.
So you dry them, you remove the wet linens, don't leave them lying on wet towels, and you place them skin to skin directly on the mother's bare chest. Then cover both of them with warm, dry blankets.
Because skin-to-skin contact is a brilliant conductive heat source.
It is, but it only works if the evaporative loss is stopped first. Dry them first, always.
Okay, so we've got the machinery working, the shunts are closing, they aren't freezing to death. Now the clock hits exactly 60 seconds.
Time for the APGAR.
Right. As a nurse, you have to rapidly and objectively quantify if this biological transition is successful, and you have to do it without interrupting the skin-to-skin bonding or the actual physiological stabilization.
Which is the genius of Dr. Virginia APGAR's scorecard. The APGAR score is performed at exactly 1 minute and exactly 5 minutes after birth.
It's basically a standardized communication tool, right? It allows the entire medical team to instantly understand the newborn's trajectory.
Exactly. It evaluates 5 parameters: heart rate, respiratory effort, muscle tone, reflex irritability, and color.
Each parameter receives a score of 0, 1, or 2 for a maximum possible score of 10.
But let's move beyond just rote memorization of the rubric. You need to understand what these parameters actually represent physiologically.
Yeah, because looking at this, it's not a detailed physical exam. It's more of a rapid neurological and perfusion proxy. Let's take muscle tone, for example.
Good one.
We know a 0 is limp and flaccid, a 1 is some flexion, and a 2 is a tightly flexed posture with active recoil. But why does that matter so much?
Muscle tone is a direct window into central nervous system oxygenation. A well-oxygenated term newborn naturally assumes a tightly flexed fetal position.
They're all curled up.
Right. But if a baby is profoundly hypoxic, the central nervous system goes into survival mode. It abandons peripheral muscle flexion, because that costs energy to preserve whatever limited oxygen exists for the brain and the heart.
Oh, wow. So a limp, flaccid baby isn't just tired from the delivery?
No, their CNS is actively signaling oxygen starvation. It's a huge red flag.
That makes perfect sense. Let's look at respiratory effort. A 0 is absent, a 1 is slow, irregular, or gasping, and a 2 is a robust, vigorous cry.
Right. And then heart rate is the most critical parameter because it drives the entire system. A 0 is absent, a 1 is less than 100 beats per minute, and a 2 is greater than 100.
Which is interesting because even though our expected baseline is higher, like 110 to 160, just getting over 100 secures those 2 points for the APGAR.
Exactly. It's about securing baseline stability. Then we have reflex irritability. This assesses the neurological response to external stimuli, like suctioning the nares or flicking the soles of the feet.
So a 0 is no response, a 1 is a weak grimace, and a 2 is a vigorous cry, a sneeze, or a cough.
Which shows the sensory pathways are intact and reactive.
And finally, we have color. And this is where we find a major exam track and honestly a very common source of anxiety for new parents.
Oh, parents freak out over this one.
Right. So a 0 is pale or blue all over central cyanosis. We already know that's a red flag. A 2 is completely pink all over. But the skull of 1 is for acrocyanosis.
Acrocyanosis, where the body is pink, but the hands and feet are blue.
And when parents see blue hands, they immediately assume the baby is choking or suffocating. I mean, who wouldn't?
Right. But acrocyanosis is a classic expected finding in the first 24 hours of life. The newborn circulatory system is still establishing its new post-placental pathways.
The vasomotor tone is somewhat unstable.
Exactly. And the body wisely prioritizes oxygenating the core vital organs over the extremities. Therefore, the peripheral circulation to the hands and feet is sluggish, leading to a blue or purplish tint.
So it only scores a 1 on the APGAR, but as a nurse, your intervention is simply to educate and reassure the parents.
Right. It's a normal, harmless part of the transition, not an emergency. Just wrap them up, keep them warm.
Okay, so with the APGAR completed, we eventually need to gather a complete set of baseline vital signs. And there are specific clinical rules for how we do this on a newborn. You can't just slap an adult blood pressure cuff on them and take a radial pulse.
No, and in fact, routine blood pressure isn't even part of the primary focus, unless there is a specific suspicion of a cardiac anomaly. The priority vitals are heart rate, respiratory rate, and temperature.
And precision and technique is everything here, right?
Everything. You do not use peripheral radial pulses to determine a newborn heart rate. They are just too difficult to palpate accurately.
Yeah, what do we do?
You must auscultate the apical heart rate with a pediatric stethoscope. You place it at the point of maximum impulse, or PMI, which in a newborn is located at the 4th to 5th intercostal space, slightly lateral to the midclavicular line.
And the critical safety rule here is the duration. You cannot just listen for 15 seconds and multiply by 4 to save time.
Absolutely not. You must auscultate the apical pulse for 1 full uninterrupted minute.
Why the full minute?
Because newborn heart rhythms can be slightly irregular as the autonomic nervous system matures. And as we discussed, there can be transient murmurs from the shunts closing. A shortcut guarantees you will miss a subtle arrhythmia that could indicate a larger structural problem.
Makes sense. And I assume the same rule applies to respirations.
Yes. You observe the rise and fall of the chest and abdomen for 1 full minute while the baby is quiet and at rest. Don't do it while they're screaming.
Right. Now, for temperature, we avoid rectal thermometers for routine checks, right?
Yes. To prevent the risk of perforating the rectal mucosa, we use the axillary route. You place the thermometer deep in the armpit, expecting a reading between 36.5 and 37.5 degrees Celsius.
Which is 97.7 to 99.5 degrees Fahrenheit.
Okay, so once the vitals are logged, we record the baseline birth weight. And here is an interesting physiological quirk that always trips people up. We actually expect the newborn to lose weight over the first few days of life.
It seems totally counterintuitive because our entire metric for newborn health is growth. We want them to get bigger.
Right.
But this weight loss isn't a loss of tissue or fat. It is a fluid shift. In utero, the placenta manages the fluid and electrolyte balance. After birth, the newborn's kidneys have to take over.
So there's a rapid increase in renal blood flow and glomerular filtration rate, essentially the infant diuresis. They pee out a significant volume of extracellular fluid that they were carrying for the transition.
Okay, but there is a strict clinical boundary for what is considered an expected fluid shift versus dangerous dehydration or feeding failure.
The highly testable metric is 10%. An expected weight loss should not exceed 10% of the infant's total birth weight.
So if a baby is born at 10 pounds, they shouldn't lose more than 1 pound.
Right. If you weigh a newborn on day 3 and they are down 12 or 15%, that is a glaring red flag.
It indicates that the fluid loss is outpacing the nutritional intake.
Exactly. It's likely due to a poor latch, insufficient milk transfer, or an underlying metabolic issue. It requires immediate lactation support and medical evaluation.
Got it. Okay, so the baby is stable, the vitals are sound, the weight is recorded. We move to the head-to-toe assessment.
This is a meticulous, organized physical inspection. We're looking for anatomical anomalies that could delay life-saving diagnoses.
And we are going to start right at the top of the head with what you flagged as the ultimate OB nursing exam question. The battle of the cranial swelling. Caput succedaneum versus a cephalohematoma.
If you take a maternal newborn nursing exam and you do not see a question comparing these two conditions, I would demand a refund.
It's that common.
It is the quintessential test of visual assessment and clinical foresight. So let's break it down. The newborn skull is not a solid, fused sphere. It's composed of separate bony plates connected by flexible connective tissue called sutures.
Right, which allows the cranial bones to overlap molding so the head can squeeze through the narrow maternal pelvis.
But that journey through the birth canal is highly traumatic.
Yeah.
The pressure from the dilating cervix and the vaginal walls often causes severe swelling or bleeding on the scalp.
And to a parent or a brand new nursing student, a giant lump on the baby's head just looks like a giant lump.
Right, but distinguishing between caput and cephalohematoma dictates two entirely different clinical pathways. Let's define the pathophysiology.
Let's do it.
Caput succedaneum is localized, superficial edema. It's swelling of the soft tissues of the scalp. It is caused by the prolonged pressure of the presenting part of the head against the cervix during labor. That restricts venous return and allows fluid to pool in the tissue.
Okay, and the memory anchor here, the visual hallmark we look for, is right in the name.
Yes.
Caput starts with a C. Crosses starts with a C. Caput succedaneum is superficial fluid, so it crosses the cranial suture lines.
It feels squishy, it is often present immediately at birth, and it is completely benign. It will reabsorb and resolve on its own within a few days without any medical intervention.
Just fluid doing fluid things. Now, compare that to a cephalohematoma.
The pathophysiology here is entirely different. This is not soft tissue edema. This is superiosteal hemorrhage.
So active bleeding.
Yes, an active collection of bleeding occurring between the skull bone itself and the periosteum, which is the tough fibrous membrane that covers the bone. It is frequently associated with operative vaginal deliveries like vacuum extraction or forceps use.
Okay, so because the bleeding is occurring underneath the periosteum, and the periosteum is firmly attached to the edges of each individual skull bone, the blood physically cannot spread.
Exactly. Therefore, a cephalohematoma does not cross the cranial suture lines.
It presents as a very well-defined, tense, asymmetrical lump constrained to one specific cranial bone, usually the parietal bone.
That visual distinction is critical. But the exam questions will target the consequence of that distinction. Why does a cephalohematoma matter so much more than caput?
Oh, this is the bilirubin connection, right?
Yes. It comes down to bilirubin. A cephalohematoma is a trapped pool of blood. Over the subsequent weeks, the infant's body must break down those trapped red blood cells to reabsorb them.
And the metabolic byproduct of breaking down HEMA is unconjugated bilirubin.
Exactly. And unconjugated bilirubin is highly toxic if it builds up in the brain. The liver is supposed to conjugate it, make it water-soluble so it can be excreted in feces and urine.
But a newborn's liver is incredibly immature.
Right. It lacks the sufficient enzymes, specifically glucuronolacyltransferase, to process a normal biological load, let alone an excessive one.
So the massive breakdown of red blood cells from a resolving cephalohematoma completely overwhelms that immature hepatic system.
Precisely. The unconjugated bilirubin backs up into the bloodstream, seeps into the tissues, and causes severe hyperbilirubinemia, clinically presenting as jaundice, a yellowing of the skin, and sclera.
So the nursing priority for an infant with a cephalohematoma is vigilant, continuous monitoring for jaundice, because they are at a profoundly elevated risk for requiring phototherapy compared to an infant with simple caput.
That is exactly how clinical reason connects the dots. Trauma leads to bleeding, bleeding leads to RBC breakdown, breakdown leads to bilirubin, bilirubin leads to jaundice.
It's just a cascade.
Exactly.
Okay, let's move down from the head to the skin. The sources list a myriad of expected dermatological findings that frankly, sound terrifying or look alarming to parents.
They do.
Let's frame these not as flashcards, but as part of the messy reality of a newborn's biological awakening. For example, vernix caseosa and lanugo.
Okay, vernix caseosa is that thick, white, cheese-like substance coating the skin, particularly in the skin folds.
It looks a bit gross, honestly.
It does, but it's an incredible biological moisturizer and barrier. It protects the fetal skin from maceration while soaking in amniotic fluid for 9 months.
Like getting wrinkly in the bathtub, but prevented by vernix.
Exactly, and lanugo is the fine, downy hair often seen on the shoulders, back, and forehead, which actually helps the vernix adhere to the skin.
Okay, so both are entirely expected. And the nursing action is to educate parents that we do not vigorously scrub the vernix off.
Right, it continues to provide an antimicrobial and moisturizing barrier. So we delay the first bath to let it absorb into the skin naturally.
Then there is erythema toxicum. The name alone sounds like a medieval plague or a chemical burn.
I know, terrible branding.
Right. When parents see this rash, which looks like red splotches with little white or yellow papules in the center, almost like flea bites, they panic.
And you can understand why. But the pathophysiology here is simply the immune system waking up. It is a benign, transient, inflammatory response.
Oh, so it's just the body reacting to the outside world.
Exactly. You have an infant whose skin has been in a sterile, watery environment, suddenly exposed to the dry, microscopic world of a delivery room. The immune system's eosinophils react, causing these papules.
So it requires zero treatment.
Zero. It is not an infection, and it will resolve spontaneously within a week or two. Your job is to preemptively educate the parents so they don't demand unnecessary antibiotics for a normal physiological reaction.
Same with melia, right? They look like tiny white pimples concentrated on the nose, chin, and forehead.
Yeah, these are just exposed sebaceous glands. The instruction to parents is strictly, do not pop them, do not pick at them. They will clear as the pores mature.
But let's look at a skin finding that requires precise clinical documentation. The slate gray nevus, previously referred to as Mongolian spots.
These are flat, bluish-gray or dark pigmented areas usually located on the lower back, sacrum, or buttocks. Most commonly seen in infants of Asian, African, or Hispanic descent.
And they are completely benign collections of melanocytes deep in the dermis.
Totally benign. However, visually, they strongly resemble deep tissue bruising.
Which makes meticulous documentation the absolute priority nursing action.
Absolutely. If a slate gray nevus is not clearly documented in the medical record at birth with its exact size and location, you run into huge problems later.
Because a provider or a daycare worker reviewing the child weeks or months later might misinterpret it as a bruise resulting from physical abuse.
Yes, and that triggers a devastating and completely unwarranted Child Protective Services investigation.
It is a perfect example of how an expected normal finding becomes a critical nursing priority simply because of the secondary implications.
Documentation is protection for you and the patient.
Let's move to the musculoskeletal system, specifically the hips. This is an area where we are hunting for serious red flags.
We are screening for developmental dysplasia of the hip, or DDH. This is an abnormal development of the hip joint, where the head of the femur is unstable or completely dislocated from the acetabulum.
So as a nurse, what visual cues are we looking for during our assessment?
You're looking for asymmetry. When you place the infant prone on their stomach, you meticulously inspect the gluteal and popliteal folds. Those are the creases on the back of the thighs and buttocks.
Okay, so checking the leg rolls.
Exactly. If those creases do not line up perfectly, or if one leg appears visibly shorter than the other, that is a glaring red flag for hip dysplasia.
And the medical provider will confirm this using the Barlow and Ortolani maneuvers. The source notes they are feeling for a clunk.
Right. During the Barlow maneuver, the provider adducts the thigh, bringing it across the midline, and applies gentle downward pressure to see if the femoral head can be pushed out of the socket.
And then Ortolani.
In the Ortolani maneuver, they abduct the thigh, moving it outward to see if the dislocated femoral head slips back into the acetabulum. If they feel a palpable clunk, the joint is unstable.
But the crucial safety trap for nursing students here is scope of practice.
Yes. The outline explicitly states, nurses do not do this.
Never.
Never. Only an experienced provider should perform the Barlow and Ortolani maneuvers.
Why is it so strict?
Because if performed incorrectly or too forcefully, the maneuvers themselves can cause severe iatrogenic injury to the joint capsule or the surrounding neurovascular structures. You can literally cause the damage you're checking for.
Okay, so as the nurse, your role is visual inspection for symmetry, identifying the red flags, reporting them, and preparing the family for a likely ultrasound of the hips.
Perfect.
Speaking of moving the baby's limbs, we have to integrate the Ballard score into our physical assessment.
The standardized tool used to estimate gestational age based on physical and neuromuscular maturity.
It's crucial because sometimes the maternal dates are wrong, right? An infant might look full term, but neurologically behave like a premature infant.
Which changes their entire risk profile for things like respiratory distress and hypoglycemia.
So the Ballard score assesses physical traits like the thickness of the skin, the presence of breast buds, and the cartilage in the ear. But the neuromuscular portion involves physically manipulating the infant to test posture, flexibility, and muscle tone.
Right. For example, the square window test evaluates wrist flexibility. And the scarf sign involves drawing the infant's arm across their chest to see how far the elbow crosses the midline.
So what's the physiological principle here?
As gestational age increases, neurological maturity increases, and therefore flexor muscle tone increases.
Okay, so a premature infant is very hypotonic and floppy.
Exactly. Their arm will pull all the way across their body like a scarf. But a term infant has tight, resistant flexor tone. Their elbow won't easily cross the midline.
And just like the hip maneuvers, there is a hard safety limit here, right?
Very hard limit. When performing the neuromuscular assessments for the Ballard score, you never force an extremity past the point of natural resistance.
So if you pull the arm for the scarf sign and the infant's muscle tone halts the movement, you just stop.
You stop. Forcing it to get a better look risks fracturing the fragile clavicle or damaging the brachial plexus nerve network. Never force it.
Okay, so we have completed the assessment phase. We know what is normal, what is a variation, and what is a red flag. We now pivot to the intervention phase: meds, labs, and procedures.
Now we have to execute the prophylactic medications and state-mandated screening safely.
Let's start with the injection given to every single newborn within an hour of birth: vitamin K. Why are we injecting a perfectly healthy-looking baby?
If you connect this back to the physiology of the gastrointestinal tract, the rationale becomes crystal clear.
Okay, let's connect it.
Humans rely on the normal endogenous flora, the bacteria living in our intestines, to synthesize vitamin K. The liver then uses that vitamin K as an essential cofactor to produce several critical clotting factors, specifically factors 2, 7, 9X, and X.
But a newborn's gastrointestinal tract has never digested anything. They have been fed intravenously via the umbilical cord for 9 months.
Right. Their gut is completely sterile.
So because their gut is sterile, they have no bacteria. Because they have no bacteria, they cannot synthesize vitamin K.
And because they have no vitamin K, their liver cannot manufacture those clotting factors. This leaves the newborn in a state of severe transient coagulopathy.
They can't clot their blood.
Exactly, making them highly susceptible to hemorrhagic disease of the newborn.
And I imagine the trauma of squeezing through a birth canal, or even just the subtle micro-traumas of being handled, could trigger spontaneous internal bleeding, particularly in the brain.
It absolutely can. So we administer a prophylactic intramuscular injection of phytonadione synthetic vitamin K into the vastus lateralis muscle of the thigh.
We are artificially supplying the factor until their gut microbiome establishes itself over the next week through feeding.
It is a brilliantly simple intervention that prevents catastrophic neurological damage.
So that's the first one. What's the second mandatory prophylactic medication?
Erythromycin ophthalmic ointment, which is applied directly into the newborn's eyes.
And this is to prevent ophthalmia neonatorum, right? A severe purulent conjunctivitis that can lead to corneal ulceration and permanent blindness.
Yes. It is primarily caused by exposure to Neisseria gonorrhea or Chlamydia trachomatis as the infant passes through an infected birth canal.
The clinical administration technique is highly specific, though.
Very. You administer a thin ribbon of the erythromycin ointment, starting from the inner canthus of the eye near the nose, and draw it outward to the outer canthus to avoid cross-contamination.
And the primary nursing education point for the parents here is a strict hands-off policy, right?
Huge point. The ointment is thick and gooey. The baby's vision will be temporarily blurred, and parents will instinctively want to grab a tissue and wipe the goop away to clean them up.
You must explicitly instruct them to leave it intact. Wiping it away negates the prophylaxis.
Just let it absorb.
Okay, let's discuss a protocol that you flagged as a major top exam trap, and one that requires urgent prioritization: the hepatitis B protocol.
Oh, this is a big one.
If a maternal client is known to be hepatitis B surface antigen positive, it means she has an active infection and the newborn was exposed to the virus in utero or during delivery.
Right.
Now, I initially assumed we would just administer the standard hepatitis B vaccine right away, but that's incomplete, isn't it?
If you select administer hepatitis B vaccine on an exam question for a positive mother, you will fail the question.
Why? What am I missing?
You have to understand the difference between active and passive immunity. The hepatitis B vaccine provides active immunity. It introduces a harmless piece of the virus, so the infant's own immune system can eventually build a blueprint of antibodies.
Right, but that process takes weeks to build up.
Exactly. And if the baby was exposed during delivery, the actual live virus is circulating in their bloodstream right now. They don't have weeks to wait, which is why they must receive both the hepatitis B vaccine and the hepatitis B immune globulin, or HBIG.
The HBIG is passive immunity. It's a concentrated dose of pre-made external antibodies that will actively hunt down and neutralize the virus in the infant's bloodstream immediately.
Holding the line while the vaccine goes to work on the long-term defenses.
So vaccine in one leg, HBIG in the other.
Exactly. And the exam trap isn't just knowing that both are required, it is the strict timeline.
12 hours, right?
12 hours. Both injections must be administered strictly within 12 hours of birth, not 24 hours.
What happens if you wait 13 hours?
If you wait beyond that 12-hour window, the virus will infiltrate the hepatocytes in the liver, and the passive antibodies will be useless.
Wow.
The infant will face a lifetime of chronic hepatitis, cirrhosis, and elevated risk for hepatocellular carcinoma. It is an absolute non-negotiable timeline.
That is the definition of a high-stakes intervention.
Very high stakes.
Okay, moving on to labs. Every state mandates a universal newborn screening, which checks for rare but devastating metabolic and genetic disorders like phenylketonuria, or PKU, congenital hypothyroidism, sickle cell disease, and cystic fibrosis.
Right, the heel stick test.
So to get the capillary blood for these tests, we perform a heel stick. But you can't just jab a lancet anywhere on the baby's foot, right?
Anatomical precision is paramount here. The priority nursing action is identifying the safe zones on the infant's heel. You must only puncture the lateral or medial aspects, the outer or inner fleshy edges of the heel.
Because if you stick the center of the heel right under the pad, you are dangerously close to the calcaneus bone.
Exactly. A newborn's foot is tiny, and the calcaneus bone is very superficial.
So if the lancet penetrates that bone,
You introduce bacteria directly into the osseous tissue, causing osteomyelitis. That's a severe, incredibly difficult to treat bone infection that can permanently destroy the architecture of the foot.
that's horrifying. So you map the heel, aim for the fleshy lateral aspect, and ensure the infant's foot is warm to promote vasodilation before you stick.
Right, get that blood flowing first so you get a good drop.
And the timing of this metabolic screening is important too, right? It's usually done between 24 and 48 hours of age, specifically because of tests like PKU.
Correct. Phenylketonuria is an inability to metabolize the amino acid phenylalanine, which is found in protein.
So if you test the baby at minute 0 before they've ever ingested protein from breast milk or formula, the test will be artificially normal.
Right. They need at least 24 hours of feeding to give the metabolism something to fail at, so to speak, in order to detect the disorder.
That is perfect clinical reasoning. Speaking of the 24-hour mark, that brings us to the CCHD screening, or critical congenital heart disease screening.
This is a non-invasive test using a simple pulse oximeter. We're looking for structural heart defects that cause right-to-left shunting.
Meaning deoxygenated blood is bypassing the lungs and slipping into the systemic circulation, causing subtle cyanosis that might not be visible to the naked eye.
Exactly.
How exactly do we set up the pulse ox probes to detect that?
You place one pulse oximetry probe on the infant's right hand. Because of how the aortic arch is structured, the right hand receives preductal blood that branches off before the ductus arteriosus.
Okay, right hand is preductal.
And then you place the second probe on either foot, which receives postductal blood.
And we are looking for two things, right? The absolute oxygen saturation and the discrepancy between the two locations.
Correct. A passing normal screen requires an oxygen saturation of greater than 95% in both extremities, with less than a 3% difference between the hand and the foot.
So if the saturation is low, or if there is a significant gap between the preductal and postductal readings, what does that mean?
It suggests a major structural mixing of blood. That is a positive screen, and it requires a comprehensive echocardiogram.
And the exam trap here relates directly back to the very first physiological concept we discussed, the shunts.
It all comes full circle. You must never perform the CCHD screening before 24 hours of age.
Because if you attempt it at, say, 6 hours old?
The ductus arteriosus is likely still in the process of closing. Some harmless transient shunting is still occurring.
And the pulse oximeter will pick that up.
Yes, you've got a false positive, and you will subject the parents to sheer terror and the infant to unnecessary expensive cardiac workups. You must respect the physiological timeline of transition.
Wait until 24 hours. Got it. So, the baby has transitioned, the physical assessment is clear, the prophylactic meds are in, and the 24-hour screenings are passed. We are moving to the final phase.
Safety, security, and nutrition.
Preparing the family for home. The medical interventions might be complete, but the nurse's job now shifts heavily into education. Let's start with sleep safety, specifically mitigating the risk of sudden unexpected infant death, or SUID, which encompasses SIDs.
The nursing education regarding sleep safety must be relentless. And more importantly, it must be consistently modeled by the hospital staff.
You can't just tell them what to do, you have to show them.
Exactly. If the parents see you propping the baby up with a pillow in the hospital crib, they will do it at home. The core directive is the Back to Sleep campaign. The infant must always be placed supine flat on their back for every sleep.
The sources are incredibly strict about the sleep environment. The crib should essentially look sterile.
It should be a fortress of nothingness. The mattress must be firm and flat. There can be absolutely no soft objects in the sleep space.
So no loose blankets, no pillows, no stuffed animals, and no bumper pads.
Just a tight-fitting sheet. Co-sleeping, or bed sharing with the parents, is highly discouraged due to the risk of entrapment or accidental suffocation by a sleeping adult.
So the safest place for the infant is in their own bassinet, in the same room as the parents, but on a separate sleep surface.
Room sharing, yes. Bed sharing, no.
Let's talk about umbilical cord care. It seems like every generation of parents gets different advice on this. Do we swab it with alcohol? Do we bandage it?
Current evidence-based practice dictates dry cord care. You do not apply rubbing alcohol, iodine, or any other antiseptics.
Why did we stop using alcohol?
Because it can actually delay the natural drying and separation process, and it irritates the skin. You just keep it clean, you keep it exposed to the air.
The practical management with the diaper.
You teach the parents to fold the top edge of the diaper down so it sits below the umbilical stump.
That prevents the cord from being constantly saturated with urine and feces, which is a massive infection risk.
Exactly. And crucially, no immersion baths. You do not submerge the infant in a tub of water until that cord stump has completely dried up and fallen off naturally.
Which typically takes 10 to 14 days. Sponge baths only until then.
Yep, just spot cleaning.
Let's touch quickly on hospital security. Infant abduction from a maternity ward is statistically rare, but it is a catastrophic never event.
Security protocols are initiated the second the infant is born. Before the mother and newborn are ever separated in the delivery room, 4 matching identification bands must be applied.
One goes on the infant's wrist, one on the infant's ankle, one on the mother, and one on the designated support person.
And any time the infant is removed from the room for a procedure and returned, the nurse must physically and verbally verify that the numbers on those bands match perfectly.
Every single time.
Every single time, no exceptions.
Okay, moving to a very difficult but necessary topic of parental education. Abusive head trauma, historically known as shaken baby syndrome.
The sources draw a very specific, tragic line between expected newborn physiological behavior and this trauma.
It's vital to recalibrate parental expectations about crying, isn't it?
It really is. A perfectly normal, healthy newborn can cry or fuss for up to 2 or 3 hours a day. Some infants with colic cry significantly more.
Crying is their only mechanism of communication.
Right. And abusive head trauma almost exclusively occurs when an exhausted, overwhelmed caregiver reaches a breaking point of sheer frustration over inconsolable crying and violently shakes the infant.
And the mechanical forces of shaking a baby, because their head is so disproportionately large and their neck muscles are virtually non-existent, cause the brain to rebound violently inside the skull.
It results in shearing of the blood vessels, causing massive subdural hematomas, retinal hemorrhages, and permanent, devastating neurological damage or death.
So what is the nursing intervention here? How do we talk to parents about this without sounding accusatory?
The intervention is proactive psychological permission. You must sit down with the parents and explicitly teach them a coping strategy.
What do you say?
You say, if you have checked all the boxes you have fed the baby, changed the diaper, burped them, checked for a fever, rocked them, and they're still screaming, and you feel that hot wave of anger and frustration rising, It is perfectly acceptable and, in fact, required to place the infant safely on their back in the empty crib, close the door, and walk away. Go to the kitchen. Drink a glass of water. Take 5 minutes to regulate your own nervous system. The baby will not sustain psychological damage from crying for 5 minutes, but they will die from being shaken.
That is such an empowering, practical piece of safety education. It acknowledges the brutal reality of sleep deprivation without judgment.
Parents need to know it's okay to walk away for a minute.
Let's finish with the topic that causes arguably the most anxiety for new parents: nutrition and feeding. The sources push the fed is best initiative, ensuring the baby is safely hydrated and nourished, whether by breast milk or formula.
But they also heavily emphasize the unique biological properties of colostrum.
Right. Colostrum is the first milk produced by the mother in the late stages of pregnancy and the first few days postpartum.
It is incredibly low in volume. We're talking teaspoons, not ounces.
Yeah.
Which often makes mothers panic that they aren't producing enough.
But it is profoundly dense in protein, fat-soluble vitamins, and minerals. It's often called liquid gold. And not just because of its yellowish color, it's essentially a maternal immune system download, right?
Exactly. The key biochemical component you must remember for the exam is immunoglobulin A, or IgA.
IgA.
Colostrum is packed with massive concentrations of IgA antibodies. When the newborn ingests this, the IgA physically coats the mucosal lining of their sterile gastrointestinal tract.
It provides immediate passive immunity against enteric pathogens and lays the foundational matrix for a healthy gut microbiome.
It is their very first defense against infection in the outside world.
Which brings us to the top exam trap for nutrition, and honestly, a trap for real life. We have all been conditioned by movies and television to believe that crying is the signal to feed a baby.
Oh yeah, the baby wails, the parents panic, someone runs to the kitchen to warm up a bottle.
But biologically, crying is a massive expenditure of energy. It is the absolute last resort alarm bell.
If you wait for the infant to scream before you initiate a feeding, you have waited too long. Crying is a late, desperate sign of hunger.
A crying baby is disorganized, right?
Completely. Their tongue is thrashing, their breathing is rapid and irregular, and they are stressed. They cannot coordinate the complex suck, swallow, breathe reflex required to latch effectively onto a breast or a bottle.
So you will spend 20 minutes just trying to calm them down enough to eat.
Exactly. So what is the clinical directive? What should parents be looking for?
You teach parents to read the whisper, not wait for the scream.
Yes. They need to identify early, subtle feeding cues. Look for the rooting reflex, where the infant turns their head and opens their mouth, searching for a nipple when their cheek is brushed.
Look for lip smacking, protruding the tongue, or the infant bringing their hands and fingers to their mouth to suck on them.
The priority nursing action is to initiate the feeding while the infant is in a quiet, alert state before the crying even begins.
Look for the smacking, not the screaming. That perfectly encapsulates the shift from reactive to proactive care. Which brings us to the final review. We have covered an immense amount of physiology, hemodynamics, and clinical judgment today.
Let's apply the Pareto principle one last time and boil this entire deep dive down to the absolute highest yield takeaways for your exam and future clinical practice.
The top 5 things to remember. Number 1, drying is paramount.
The biggest immediate threat at the moment of birth is evaporative heat loss. A cold baby burns brown fat, which rapidly consumes oxygen, throwing them into the irreversible hypoxia-hypothermia death spiral. You must dry the infant instantly and thoroughly.
Number 2, the battle of the cranial swelling.
Caput succedaneum is harmless, superficial fluid that crosses the cranial suture lines. Cephalohematoma is trapped, superiosteel blood that does not cross the suture lines, and as that blood breaks down, it drastically increases the infant's risk for severe hyperbilirubinemia and jaundice.
Number 3, the hepatitis B protocol.
If a maternal client is hepatitis B positive, providing the vaccine alone is a critical failure. The newborn must receive both the active immunity of the hepatitis B vaccine AD, the immediate passive immunity of the hepatitis B immune globulin HBIG, and both must be administered strictly within 12 hours of birth.
Number 4, differentiating color.
Acrocyanosis, blue hands and feet, is a normal expected finding in the first 24 hours due to sluggish peripheral shunting. Central cyanosis, a blue trunk, lips, or face, especially when accompanied by grunting, flaring, or retractions, indicates severe respiratory distress and requires immediate emergency intervention.
And number 5, crying is a late sign of hunger.
Do not wait for the alarm bell. Teach parents to look for early feeding cues like the rooting reflex, lip smacking, and hand-to-mouth movements to initiate feeding early and successfully.
Well, there you have it. You have officially survived OB nursing boot camp. We've navigated the murky, high-stakes waters of the delivery room, separated the normal physiological quirks from the deadly red flags, and hopefully armed you with the clinical reasoning you need to excel on your exams and on the floor.
It's a lot of information, but it saves lives.
Thank you, as always, for your incredible insight and for keeping us focused on the why behind the safety.
It has been a privilege. But before we sign off, I want to leave you with one final, broader perspective to mull over.
Okay, let's hear it.
Throughout this hour, we have focused intensely on the brutal physical mechanics of these first 24 hours. We've talked about pressure gradients, slamming heart valves shut, fluid being squeezed out of alveolar sacs, reflexes firing, and blood sugar stabilizing.
Right, it feels very mechanical, very task-oriented. It feels like an engineering checklist just to keep the biological machine running.
It does. But consider the invisible, lifelong foundation that is being laid at this exact same moment underneath the mechanics.
What do you mean?
The specific bacteria in that first drop of colostrum, that IgA we discussed, is right now, in real time, actively programming the infant's immune system for decades to come.
Wow.
The simple act of placing that naked, wet baby skin to skin on their mother's chest isn't just about preserving thermal heat. The tactile stimulation and the maternal heartbeat are literally wiring the infant's central nervous system for human attachment, emotional regulation, and psychological security.
So the transition isn't just about surviving the shift, it's not just a checklist.
Not at all. As a nurse, you aren't just keeping a newborn alive for your 12 hours on the unit. Every rapid intervention you make, every subtle anomaly you catch because you understand the physiology, every moment of grace and education you provide to those exhausted, terrified parents.
You are actively participating in the physiological and emotional construction of a human being's entire future.
The biological transition of birth never really stops. It just echoes forward into the rest of their life.
What a profound and humbling way to look at it. From the pressure mechanics of a fetal heart shunt to the messy, beautiful reality of securing a new life. Keep applying that critical thinking, and until next time, keep diving deep.